Welcome to everybody in the anesthesia department of Cairo University, and this is one of the lectures where we are giving a hint about the updates of evidence-based recommendations for pain control after major knee surgeries. I am Dr. Nagi Amar, and I'm professor of anesthesia and ICU in the Faculty of Medicine. Uh, in this talking about mainly major knee surgeries, which are ACL reconstruction and total knee arthroplasty TKA. We need to outline the incidence of post-operative knee pain, the benefits and adverse effects of opioids as well as non-opioid agents and techniques, current available evidence-based recommendations for the management of such pain to achieve functional. The question is coming like this: what is the best treatment for post-operative pain after major knee surgeries? And we need to answer two questions: how to search for an answer with a reliable evidence, and how to assess the quality of this evidence. Quality and credibility means we are looking for original articles. But what about textbooks? Textbooks are published every 4 years, so it might not be updated, and more importantly that chapters are single authored, not peer reviewed, so it is biased. So we are looking for original articles through the database Midline and base using the PubMed, Ovid or Cochrane. You need to retrieve and appraise the article and test the strength of this article against the pyramid of evidence, where the base is the weakest evidence and the top is of the pyramid is the strongest evidence. We have the in vitro, the animal study, the ideas, editorials, opinions, case reports, case series, case control, cohort studies, and the gold standard of the evidence, which is randomized controlled double-blind uh, studies. We call it randomized controlled trials in short, RCT, and critical appraisal of many RCTs from different centers. We have what we call it systematic reviews and meta-analysis. For example, in the PubMed, we are looking for the systematic review like this. The Cochrane library, we search for reviews, and systematic reviews and meta-analysis summarize and interpret well-conducted controlled trials. So what is evidence-based medicine? It is research evidence that you are getting from original article in the presence of clinical circumstances of the institution or the place where you are working, in the presence of patient preferences in the community or location you are working, all gathered together by clinical expertise. We call it recommendations, which are help to guide target driven care, which is associated with better outcome. So these recommendations are classified into A, B, C, and I. A, the recommendation indicate that the intervention improves important health outcome and the benefits substantially outweighs the harm. Much difference. Level B, the benefits outweighs the harm. The level C, the intervention is ineffective or the harm outweighs the benefit. And level I, the evidence for intervention is low. Classification by U.S. Preventive Task Force, which is a group of independent volunteers and experts in the disease prevention and evidence-based medicine. They are classifying into level 1, 2, and 3. Level 1, the evidence is obtained from at least one properly gold standard randomized controlled trial. Level 2, 1 without randomization. Level 2, 2 cohort case control analytical studies, preferably from more than one center or research group. Level 3 dramatic results in uncontrolled trial, and level 3 opinions of respected authorities and experts. The incidence of moderate to severe pain after major knee surgeries have been reported as roughly 50%. Early ambulation and physical therapy are essential for functional recovery, long-term functional. After the pain stimulus, the nerve impulse is traveling through the nerve AC, A delta fibers and C fibers to the posterior horn of the spinal cord, is ascending in the spinothalamic tract, relying in the cerebral cortex, and the pathway of pain is multifactorial. And the management, hence, for the management of post-operative pain should be multimodal. Independent predictors for moderate to severe post-operative pain after major knee surgeries include high preoperative pain scores, depression. By multimodal, we mean inhibit the complex pathway at multiple sites. We have the preemptive analgesia, central and peripheral. We have the opiates, patient control analgesia, transdermal opiates. We have non-opioid analgesics, NSAID, gabapentin, paracetamol, and pregabalin. We have the epidural analgesia, and lastly, we have the local infiltration and peripheral nerve blocks. Narendra Rawal described the progress of this in anesthesia, that before the 80s we have the general anesthesia plus IM opioids, IV opioid and patient controlled analgesia near the 90s. After the 80s we have the neuroaxial block, epidural, spinal, combined spinal epidural, and in the 90s we have the peripheral nerve block, femoral sciatic and lumbar plexus block, and currently we have the local infiltration analgesia, femoral nerve block, adductor canal block, IPAC block, in addition to the use of long-acting local anesthetic. The preemptive analgesia means administration of analgesia prior to the painful stimulus to prevent central sensitization. Evidence for that in the randomized controlled trials is available. Preemptive administration of ketoprofen, which is NSAID, reduces postoperative scores. A randomized controlled trial 2004. Morphine, if given 1 hour before the surgery, is proven to reduce postoperative usage of morphine itself independent of the dosage. 2018 randomized controlled trial. Early stage periarticular injection during TKA may provide better post-operative pain relief than the late-stage 2018 randomized controlled trial, and intraoperative continuous low-dose racemic ketamine infusion, 6 microgram per kg per minute, reduced pain and post-operative anesthesia consumption without affecting the incidence of side effects. Randomized controlled trial 2000. The opioids are used in moderate to severe pain. They are used both for nociceptive and for the neuropathic pain, and have no ceiling effect. They can relieve any type of pain, but at rest. Of opioid analgesia today: gastrointestinal side effects, impairment of motility, secretions, nausea and vomiting, urinary retention, urticaria, mental impairment, potential for addiction, inability to control pain on movement. This is the most limiting factor. Rehabilitation. We have also the non-opioid analgesics, the NSAID, the paracetamol. Both are decreasing or having opioid sparing effect of 20 to 30%. This is a systematic review, anesthesia analgesia 2010. Controlled trials are included in the study, and there is no evidence of increased incidence of side effects with combination compared with an individual drug alone. which is very good advantage. The pain intensity and analgesic supplementation, we have got 35 to 38% lesser than the paracetamol group alone. We have 37 to 31% lesser versus the NSAID group. So the combination is better. The conclusion, current evidence suggests that combination of paracetamol and NSAID may offer superior analgesia compared with the either drug alone. This is level A, where the benefits substantially outweighs the harm, and it is level 1 for at least from one randomized control. The epidural is systematic review, another systematic review by Peter Coy from McMaster University, and he is studying the epidural analgesia versus systematic analgesia following knee and hip replacement. Is lumbar epidural analgesia more efficient than systemic analgesia or long-acting spinal analgesia for post-operative pain relief in patients with elective hip or knee surgeries? Conclusion, epidural analgesia may be useful for post-operative pain relief following lower limb joint replacement, and epidural infusion of local anesthetic or local anesthetic narcotic mixture better than the epidural narcotic alone, and the magnitude of pain relief must be weighed against the frequency of adverse effects, and the current evidence is insufficient to draw the conclusion on frequency of rare complications from epidural analgesia, post-operative morbidity, mortality, functional outcome, and length of hospital stay. This is published 2003 by Peter Coy, and he republished the same data in 2013. Major complication of epidural analgesia. A retrospective case note review was done by Christie from UK and Maccabi from Australia, starting in 2000 and the year 2000 and ending 2006, and published in 2007. They studied 8,100 patients, 6 cases of epidural abscess, 3 cases of meningitis, and 3 cases of epidural hematoma. And the symptoms of epidural abscess and meningitis developed a median of 5 days after epidural catheter removal, while the symptoms of epidural hematoma developed while the catheter is still in place. Diagnostic delays contributed to adverse neurological outcome in 3 patients, and the study suggested that leg weakness is a critical monitor for spinal. ASRA to introduce the evidence-based guidelines, the 4th edition in 2018, published in Regional Anesthesia and Pain, and according to the classification, neuroaxial block and deep non-compressible peripheral nerve block are high risk in regional anesthesia in patients receiving antithrombotic or thrombolytic therapy. They are the consensus of this group represents the experience of recognized experts in the field of neuroaxial anesthesia and anticoagulation, and according to them recommendation, protocols must be in place for urgent MRI and hematoma evacuation if there is change in neurological status. We must focus on rapid diagnosis and treatment to optimize the neurology. The limitation of epidural analgesia after knee surgeries are in patients with anticoagulation and increased risk of neurological complications, and in patients with cardiac morbidity, significant hemodynamic changes. The adverse effects are including risk of fall, urinary retention, and a question, is epidural analgesia still a viable option for enhanced recovery after knee surgeries? And the answer is coming in this study, Anesthesia and Analgesia, published in British Journal of Anesthesia 2018 for knee joint arthroplasty by Donnell from Glasgow. And the statement, benefits of epidural anesthesia with surgical outcome have been well documented in the literature. However, the epidural anesthesia has significant failure rate and requires more intensive nursing vigilance, including high dependency admission to manage hypotension combined with the potential for adverse effects including urinary retention, pruritus, nausea and vomiting, motor blockade. Epidural anesthesia delays recovery after TKA and often regarded as incompatible with enhanced recovery protocols. To the fruits of this lecture, regional block of knee surgery. According to Hilton's law, any joint is innervated by articular branches of the muscles which move the joint. For the knee joint, we have the femoral, obturator, and knee joints, and the sciatic are providing movement of the ideal analgesic block should offer adequate analgesia with little or no effect on the motor power to allow the safe early ambulation. So we have non-motor sparing nerve blocks, femoral, sciatic, obturator nerve, provide excellent analgesia, disadvantage quadriceps, paresis, and foot drop. The motor sparing blocks, we have local infiltration analgesia, adductor canal block, and the eye back. The femoral nerve block, which is non-motor sparing, is indicated for femur, patella, quadriceps, tendon, and knee surgeries, analgesia for the hip surgeries. Femoral nerve block can add to the anesthesia timing after spinal anesthesia if combined with sciatic nerve block or obturator nerve, better analgesia is added. Do we need nerve stimulation to get high quality block? And the answer in randomized control trial by Kim 2016, ultrasound guided continuous femoral nerve block alone is associated with similar outcome but reduced procedure time compared with the ultrasound guided with nerve stimulation guidance for continuous femoral nerve block in patient undergoing TKA versus epidural continuous femoral nerve block randomized control trial 2017. Conclusion, continuous femoral nerve block provide post-operative analgesia equivalent to those obtained with continuous epidural anesthesia with fewer side effects. Mainly the bilateral block is motor block is lacking. It is only one side, and the opioid side effects are less. If combined with sciatic nerve block, femoral nerve block, and meta-analysis, 10 randomized control trials comparing the combination to the single, and 3 randomized control trials, single injection to continuous flow of sciatic nerve block. And the conclusion, combination of sciatic nerve femoral nerve block appears to be optimal choice for patients with high risk of post-operative opioid consumption or acute pain after TKA. A continuous sciatic nerve is better than single. The best is the motor sparing analgesia. The femoral nerve block, which is non-motor sparing, is indicated for femur, patella, quadriceps, tendon, and knee surgeries, analgesia for the hip surgeries. Femoral nerve block can add to the anesthesia timing after spinal anesthesia if combined with major components of the local infiltration concept is high volume up to 150 ml, long-acting local anesthetic ropivacaine or liposomal bupivacaine, non-local anesthetic adjuvants, epinephrine, NSAID, and opioid steroids. The locations are areas densely innervated, suprapatellar pad of fat, collateral ligaments, meniscus capsule, posterior capsule, intercondyle. Versus epidural local infiltration analgesia, a systematic review, 7 randomized controlled trial, 251 patients. A conclusion: local infiltration analgesia equivalent in efficacy to epidural after TKA and shows increased range of motion because lack of motor block and reduction of the occurrence of nausea and length of hospital stay. Versus the femoral nerve block, local infiltration analgesia meta-analysis published 2015. 9 randomized controlled trials, 782 patients. No significant pain difference in the pain intensity or opioid consumption in both groups, femoral nerve block and local infiltration analgesia. Based on the current evidence, local infiltration analgesia seems to have an effective as femoral nerve block, even better during the first 6 hours, easier to perform than the femoral nerve block with TKA. Added benefits: no motor block. I started using this in 2015 in addition to the adductor canal block and having a good. The adductor first described saphenous nerve block ultrasound guided by Kirkpatrick in 2010 but as a letter to the editor in regional anesthesia and pain. He was using ultrasound and color Doppler they referred to as superficial femoral artery saphenous technique, and according to them it seems that it's not necessary to visualize saphenous nerve in order to do the block successfully. And up till 2011, Lund and colleagues first applied the concept of performing adductor canal block for the purpose of analgesia after major knee surgeries. They were introduced the first perineural catheter and established that 30 ml of anesthetic could effectively fill the adductor canal. And Henningsen tested the saphenous nerve injury in 2013 to describe the safety of the technique. They demonstrated that no patients suffered saphenous nerve injury and over 80% of the patients have successful block. This study highlighted two important aspects of the technique. It established the technique safety, which I query describe it is not safe as long as you are describing the whole structures in the adductor canal, not only the nerve. And demonstrated that even under controlled conditions, it is not 100% effective. Most of your colleagues will notice this, that it is not 100% block in all cases, I mean. The adductor canal aponeurotic sheath that is extending from the apex of the triangle here to the adductor hiatus in the popliteal fossa and is bound medially by the sartorius, laterally by the vastus medialis, and posteriorly by the adductor canal. Within the aponeurotic sheath, which is triangular shape here, there is consistently the saphenous nerve and nerve to the vastus medialis, in addition to the artery and the vein. And outside the aponeurotic sheath, we have the subarterial plexus, which is a group of nerves, branches of the obturator nerve, medial retinacular nerve, the medial femoral cutaneous. The radiologists describing that visualization of the nerve can be done, the saphenous nerve can be easily obtained in the proximal part of the adductor canal using high. If combined with sciatic nerve block, femoral nerve block, and meta-analysis, 10 randomized controlled trials comparing the combination to the single, and 3 randomized controlled trials, single injection to continuous flow of sciatic nerve block. And the conclusion: combination of sciatic nerve femoral nerve block appears to be optimal choice for patients with high risk of post-operative opioid consumption or acute pain after TKA. A continuous sciatic nerve is better than single shot. Uh, Comparing proximal to the distal in the adductor canal. This is the subject of the study published in regional anesthesia, published in regional anesthesia and acute pain. And by proximal, we describe the left picture, the left photo of this diagram, where there is a sartorius muscle, and beneath is a superficial femoral artery lying in a more medial location to the muscle. While we are going with the probe more distally, the same superficial femoral artery will move from the medial location to more lateral position. And the block, proximal and distal, the study demonstrated that continuous proximal adductor canal block offers non-inferior analgesia compared to the distal continuous adductor canal block after TKA, which I object for this terminology in English, because as a general rule, while you are going more proximal, you have get a better analgesia. So if he is describing his terminology, it should be like this, that continuous distal adductor canal block offers non-inferior compared with the proximal one.
Now this is a superficial femoral artery.
The adductor canal block
on the medial side
of
the sartorius muscle under the sartorius cover. This is proximal in the adductor canal block and baby in the femoral triangle. We are going more laterally. The artery is going more laterally, and here is this is lateral, and the other side is medial. So now in this position is more lateral. The block is here is equivalent to the sartorius muscle under the sartorius cover. This is proximal in the adductor canal block and baby in the femoral triangle. We are going more laterally. The artery is going more laterally. And here is
more going distal,
and the other side is medial. So now in this position is more lateral. The block is here is equivalent to the first one, but less motor paralysis. Now down.
And here is the color Doppler to show the artery. It's better to use
this is the femoral artery
to know your anatomy.
It is more on the medial side, more proximal.
Here is the artery location. This is the muscle, and this is the artery and vein.
If we are moving more distally, it moves from the medial to lateral, where it is now more lateral. This is the proximal 1/3 of the adductor canal. And the hyperechoic mass on the lateral side of
the radiologists describing that visualization of nerve can
now the needle is coming from lateral to medial, approaching,
in the proximal part of the adductor canal,
penetrating the muscle, and now I feel a resistance. This is the fibrous sheath that covers the adductor canal. Now few cc's. This will block the subarterial plexus of nerves, including the branches of the obturator nerve. Yeah. Now I'm penetrating the resistance. Now penetrated, and hyperechoic mass. This is the saphenous nerve. Inject after withdrawal. Withdraw first. Inject. No blood.
No blood.
Yeah. Inject. Inject. Yes. Inject. Withdraw.
John doctor. And inject.
Inject. Yeah. Now the saphenous nerve is floating now.
Can I inject full?
Yeah. Inject. 20 ml total.
Yes, sir.
Give me 5 ml more because you give extra adductor canal. 5 ml. So we need a 20 ml within the adductor canal because the capacity of the adductor canal give 5 ml is around 20 to 30 ml.
Okay, doctor.
Thank you. This is finished.
So, femoral nerve block versus adductor canal block. In which surgery? In anterior cruciate ligament reconstruction. Two studies came from Arabic researchers. The first one is assistant professor in Ain Shams University, very good researcher, Muhammad Said Al Ahl, and he's working in Emirates. And the second one is Faraj Abdullah, he's working in Toronto General Hospital, and he's from Lebanon. And the first one published in Saudi Journal of Anesthesia 2015, and the second one published in Anesthesiology 2016. Both are studying. They have a randomized controlled trial comparing the adductor canal block with the femoral nerve block for ACL reconstruction. Both are randomized controlled trial. Both groups superior quadriceps strength in the adductor canal group, and pain control differed in the two groups. Abdullah found that both groups are equal. I mean, it's effective as the femoral nerve block. While Muhammad Said Al Ahl reported lower pain intensity around 18 to 24 hours in the group with having femoral nerve block. So discrepancy could be attributed to the nature of the graft in the two groups are different, and the volume of local anesthetic 20 ml in Abdullah group, 15 ml in Muhammad Said Al Ahl group. So we need additional trials to confirm. And in 2017, I have met, this is Faraj Abdullah. I met him in Abu Dhabi while I'm giving a lecture about the knee pain, and he was giving another lecture about the same subject. And he told me that the difference between his study and Muhammad Said Ahl, he confessed that he was injecting more proximal, actually in the femoral triangle block, midpoint of the thigh. So this can also explain the better results for the adductor canal block in Faraj Abdullah. So also in the total knee, the adductor canal versus the femoral nerve block, meta-analysis published 2017 by Duan in Scientific Reports, and it included 12 randomized controlled trials. Adductor canal block provide pain relief and opioid consumption comparable to the femoral nerve block and is associated with decreased. Another study 2018 having another aspect of in the total knee block, that early rehabilitation and lateral knee pain relief. It is randomized controlled trial, similar analgesia for both groups, adductor canal and femoral nerve block. Opioid consumption, complications, occurrence, sleep interruption caused by pain, all are the same. In addition, adductor canal block having better rehabilitation, I mean better movement, but early rehabilitation is associated with lateral knee pain. So, adductor canal block could not relieve lateral pain on early rehabilitation.
Now this is the superficial femoral artery. It's on the medial side of the sartorius muscle under the sartorius cover. This is proximal in the adductor canal block and baby in the femoral triangle. We are going more laterally. The artery is going more laterally, and this is lateral and the other side is medial. So now in this position is more lateral. The block is here is equivalent to the first one, but less motor paralysis. Now, thank you.
The limitation of epidural analgesia after knee surgeries are in patients with anticoagulation and increased risk of neurological complications, and in patients with cardiac morbidity, significant hemodynamic changes. The adverse effects are including risk of fall, urinary retention, and pruritus. To have more bad news for the adductor canal alone is a case report by Faraj Abdullah from Toronto General Hospital and Lyon. Femoral artery dissection after adductor canal block, uneventful ultrasound guided adductor canal block, post-operative absent distal pulsation and arterial duplex scan demonstrated femoral artery dissection flap. Color Doppler demonstrated absent arterial flow to the distal to the dissection, and at surgery a puncture site with perivascular hematoma and intravascular thrombus emergent thrombectomy and arterial repair. The patient subsequently regained. The last is the eye back block. The first introduced by Sanjay Sinha from New York, and the eye back block stands for infiltration between the popliteal artery here and the capsule of the posterior knee here, blocking the articular branches of the tibial common peroneal obturator nerve in the popliteal. The injection is done while the patient lying supine, flexed knee, the needle passing from medial to lateral between the artery and the capsule away from another study 2018 confirmed what Sanjay Sinha presumed. The frequency map of articular branches, where the posterior branches of the common tibial fibular nerve, sciatic nerve are in red, the posterior division of the obturator nerve in blue, the superior branch of the tibial is in green, and the inferior branch of the tibial in violet. This is published in 2018 by a group of investigators from Toronto, mainly Philippine, the head of the department. And according to the study, the frequency map of articular branches provide anatomical basis for the development of new clinical protocols for knee radiofrequency denervation and perioperative pain management. To have more bad news for the adductor canal alone is a case report by Faraj Abdullah from Toronto General Hospital and Lyon. Femoral artery dissection after adductor canal block, uneventful ultrasound guided adductor canal block, post-operative absent distal pulsation and arterial duplex scan demonstrated femoral artery dissection flap. Color Doppler demonstrated absent arterial flow to the distal to the dissection, and at surgery a puncture site with perivascular hematoma and intravascular thrombus emergent thrombectomy and arterial repair, the patient subsequently regained perfusion. The last is the eye back block. This is the
against the lower end of the femur, and this is the posterior capsule, the white line. I am infiltrating between the posterior artery and the posterior capsule of the knee, and you see to the left of the artery the two branches of the sciatic nerve we are injecting away, so no motor block. This is the posterior capsule, the white line. I am infiltrating between the posterior artery and the posterior capsule of the knee, and you see to the left of the artery the two branches of the sciatic nerve we are injecting away, so no motor block. The injection from medial to lateral.
The needle passing from medial to lateral in the artery,
and we are deeper to the artery. Now in the against the posterior capsule, now inject. Yeah, injection now between the capsule. Any resistance?
No.
Okay. Give 5 ml.
Yeah, 5 ml given.
Stop. Now I am redirecting the needle to go more laterally. Now, yeah. Now inject. 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 Yeah. This is the lateral injection between the capsule and the popliteal artery. Give full dose. Thank you. Done.
So I realized that I should compare what is the effectiveness of this IPAC block, and to compare this, what I did, I added the adductor canal block to the IPAC block. I am doing it pre-operatively before the surgery is starting, and the control group is I'm doing pre-operatively the adductor canal block and letting the surgeon doing local infiltration analgesia at the end of surgery. And the Cochrane library, we search for reviews and systematic reviews and meta-analysis summarize and interpret well-conducted controlled trials. Sample size. However, I didn't find this comparison in RCT except in another type of surgery, which is TKA. The first one is published in 2017 by Salman from New Orleans, He was studying three groups. The first group, femoral nerve block. The second group is femoral plus eye back block. And the third group, adductor canal block plus eye back block. And what we got? Eye back block reduced opioid consumption if added whether to the femoral nerve block to adductor canal block. Adductor canal block with eye back block provide equivalent analgesia to the femoral nerve block and the eye back block. Physical therapy is easier, no motor block, and allowing earlier hospital. They have a randomized control trial comparing the adductor canal block with the femoral nerve block for ACL reconstruction. Both are randomized control trial. Both groups superior quadriceps strength in the adductor canal group, and pain control differed in the two groups. Abdullah found that both groups are equal. I mean, it's effective as the femoral nerve block. While Muhammad Said Al-Ahl reported lower pain intensity around 18 to 24 hours in the group with having femoral nerve block. So discrepancy could be attributed to the nature of the graft in the two groups are different, and the volume of local anesthetic 20 ml in Abdullah group, 15 ml in Muhammad Said Al-Ahl group. So we need additional trials to confirm the same combination, which is adductor canal block and eye back block, was used in pain relief. This study published in Anesthesia Essays Egyptian journal by Said Imam and Ines from Mansoura University. They were injecting this combination and comparing with the adductor canal block. The technique combined adductor canal block eye back block provides more effective analgesia and better functional outcome compared to the adductor canal alone in patients suffering arthritis. Just to hint that there is more promising techniques, which is quadratus lamborum and erector, which is the article of another two lectures that I'm intending to publish also to put it on the group, which is thoracolumbar fascia, understanding thoracolumbar fascia and quadratus. The first introduced by Sanjay Sinha from New York, and the IPAP block stands for infiltration between the popliteal artery here and the capsule of the posterior knee here, blocking. And the other lecture, which is erectospinal plane block versus paravertebral block. According to Hilton's law, any joint is innervated by articular branches of the muscles which move the joint. For the knee joint, we have the femoral, obturator, and knee joints, and the sciatic are providing movement of this knee joint. And the take-home message of this lecture is pain management for the knee should be thought of as multimodal rather than monotherapy. Combination of paracetamol and NSAID is safe and highly effective, particularly if started pre-operatively. Opioids cannot remove pain or movement, therefore not the ideal single therapy for rehabilitation. And the motor sparing peripheral nerve blocks result in faster return in normal life activity. extended analgesia with single injection of combined block is becoming a reality with introduction of ultrasound-guided regional block and added adjuvants. The synergistic effect of combined blocks probably prolong the duration of sensory block. The most effective practice for pain control is by incorporating preemptive analgesia, multimodal analgesic regimen with paracetamol, NSAID, and gabapentins, and a combination of motor sparing regional techniques that target the terminal sensory endings of the femoral obturator and sciatic nerve are the best. If anyone interested to join me in WhatsApp, here is the WhatsApp uh, numbers. I'm uh, welcoming any question or any illustration or clarification. Thank you very much.